are talking about the Service Delivery Indicator Survey for the year 2018 that was put together by various organizations, including the Ministry of Health and also the National Council for Population Development, amongst others. With me still in studio is Simon. He is the Secretary General of the KMA, that's the Kenya Medical Association, and also Peter. He is the Technical Director at the National Council for Population Development. Thanks for staying with us. We have been discussing the report, and it has revealed various statistics, some more startling than others, some statistics that show that we have improved in various areas, but some that show that we are still complaining about the same issues. I'll start with you, Peter. How would you describe the current state of health in the country?
You can look at it from the perspective where we have moved up to now. And I think with the reforms that were done in the 90s and the 2000s, we were progressing very well, and the indicators were improving. And you remember when the 2004 Demographic and Health Survey indicated that we are reversing. The findings assisted the ministry and other stakeholders in the health to refocus, and the health reforms were undertaken. And we have been performing very well. If you compare Kenya indicators across the region, we are doing very well. We are doing well than many of the other countries. But with this result, there seemed to have been a slow progress. That pace we were having, we were interrupted, kind of. And I can say we need now to refocus again, bring the stakeholders on board, so that we fix those small things. Some of the things which are there are very easy to fix if there is a third concerted effort on the issue of human resource. And that's one of the things we are saying. With this study, now we need to focus. We meet in charge, those who are in the human resource for health. What are those quick gains we can make? Improve. Like one of the things in the report is the issue of adherence to clinical guidelines. The ministers developing a lot of guidelines, but when you go to the ground, those guidelines are not there. So how do you expect a service provider to adhere to guidelines which they don't have?
Right.
It's something which can be done if there's partnership with KMA and other stakeholders to disseminate and widely those guidelines, so that we put at the center the client. When you are offering the service, you are adhering to the guidelines. Right. That's what's lacking. And that's an area we need to look at. I can say there's room for improvement, and there is opportunities and goodwill from all actors in the health sector.
Okay, I will come to the point of partnership and collaboration later. Simon, you sit on a different perspective. You are in the profession, you are a doctor. You mentioned earlier that a lot of what's in this report, you as medical personnel know. How would you describe the current state of health from where you sit?
So healthcare service provision is, is teamwork and has to be looked at holistically. So traditionally, we have characterized health service under various headings. So we have governance and leadership for us, which is the most important. The person who gives policy direction in leadership. Then we have human resource. Then we have pharmaceuticals and pharmaceutical supplies. Then we have health service delivery indicators. Then, so those are the aspects that you need to assess. So human resource, generally my line of interest. From the time of devolution, there has been, from 2013 onwards, 60 plus strikes of human resource. You cannot say that is teething problems. Currently, as we speak, Kirinyaga and Laikipia, the doctors are on strike. The governors have decided to have a lockout. And the health indicators, as he has put it, of Kirinyaga, have gone down. And Laikipia, they used to be top performing governors. So what is the problem? The problem is management of human resource. So the management of human is not as it was before.
And who's responsible for that management? Is it the county governments, the national governments?
And that's the problem. So previously it was clear. You have the Public Service Board, is in charge of all workers, both civil and therefore deployment, terms of employment are clear and how do you call it, uniform, similar. If I am a gynecologist in Murang'a, for instance, which I am, and a gynecologist in Mombasa, there is no reason why their terms of condition should be different.
Right.
And but currently, in the devolved state of governance, one, employment of doctors has stopped from 2013. As the population of Kenya increases and the UHC takes place, the population of people coming to hospitals has increased, yet the policy direction in a devolved governance is not to employ. Two, the natural progression of a doctor is become a medical officer. I'm using doctor as an example, but this can be escalated to all other health workers.
Right.
Work for some time and improve both your, how do you put it, experience, and you become more. The more you see and
more exposure.
more exposure you have. So work for 3-4 years. Then now when you now have the holistic picture of how health is, specialize in an area which you have already covered. Right. So that helps solve two problems. One, service delivery at this point. So these 3 to 4 years, you're serving as a general doctor, medical. Then you specialize into one of the fields, but we are still producing more. So the field that you have left will not be covered, but it's only be covered if someone is employed to replace you when you go for further training. You see, that died. And therefore, and I saw Building Bridges initiative, we made our presentation. We want a health service commission. Why? Currently, and we are facing a situation where doctors want to go to school. But the governors are saying, no, you've seen the fight with county, with the national government, they're even marching in the street. Our governor says, no, we don't have money to pay you to study while you are in Kenyatta for 5 years, you are not providing service. We say that's well and good. What you need to fight for is a health service commission whereby it's controlled at a central level because we know the needs of the whole country. When time comes for you to go to school, you are given back to that body. Right. And they train you and educate you and bond you. You know, what we fail to see is that the training is not in vain because you have been trained for this number of years. You have to work for this number of years at where we want to deploy you. So you don't get problems like those ones who will work in Majiri. And I'll give myself as an example. When I was a medical officer intern, I was in Machakos. Worked for Machakos for 3 years. Improved the hospital by the way they cannot... we made the hospital the way it is. It was a long time ago.
Credit
and then after that, the government sponsored us to training in school 3.5 to 4 years and bonded us. So I was posted to Isiolo as a gynecologist. Isiolo, I'd never seen a gynecologist. And why? Because when I finished, Machakos still had a gynecologist, so I couldn't go there. There is already, their service delivery is already covered. Isiolo had no gynecologist. So I was there for 5 years, both as a DMSO, medical superintendent, and provider. And you can go to the records, the hospital improved. So what we are saying is that we need to look at healthcare from a country level rather than from a county level. Murang'a today may not need a gynecologist, but Wajir does. Therefore, Murang'a will not release someone to go to school to do gynecology because they don't need one, let's say. But Wajir need one, but they don't have anyone to release to go do, to come cover. You get what I mean? And health, we are saying a health service commission is necessary. So in terms of human resource management, the Kenya Medical Association, the union, and even NCPD, I was discussing with her, actually sees the impact of having a centralized management of human resource. Nursing, you need them to specialize. We are complaining about Mama Lucy Hospital. Why? Because you do not have people who are trained, for instance, midwifery. You need a special, you need the quality of improvement. The guidelines, dissemination as he puts it, we need to disseminate them. Right. So if you measure someone and say he's not following the guidelines, he does not have the guidelines. Let's see. You see. So that's the state is that it's patchy. Right. Different counties have different levels of service healthcare provision. Yeah. and they need to be analyzed on their own. The biggest problem is not the infrastructure, which as we have seen has increased,
Yeah.
is MES
Yeah.
and all, but the human resource component is a big issue.
Right.
And the danger with that, and mark my words, in 20 years we'll see, is that the quality of service provision, if the human resource aspect is not addressed, will continue going down. As much as you will say, the governor says, oh, I don't need to train anyone, but they are lessening the quality of future care in their service. Why? Medicine is highly hierarchical and dependent on time and money. So the situation as it were, medical officer interns currently are the ones we have managed to retain as automatic payment. They finish, they leave. So what happens is joblessness in the country generally. So they go hustle, sell cars, you know, they are not practicing within a confined space, which is necessary for improvement of quality education. So they are selling cars, land, I don't know what. They're not practicing what they were taught to 6 years. They were going to school then. So why? Because of both the economy and so in 1 year, the half-life of medical knowledge is 1 year. It means that you need continual renewal. So it's not there. And that can only happen, by the way, in sort of a government setting where you are working for a minimum amount of time, because you're seeing volumes, you have a salary, and you are giving service provision. And therefore, the quality in the near future will now start coming down.
Okay, well, that is a big concern.
Big concern.
If indeed it is true. Peter, do you believe there is political will and do we have the right sort of leadership to make the changes that we need? Because year in, year out, when I host such conversations, a lot of the time we're talking about the same thing. Nothing changes. Why is that, in your view?
That's a hard one, but what I can mention is that what Dr. has said is correct. And if you look at that report, we started by first saying we need the right forum and the right mix. The skills. It is not a one-off. It's a continuous improvement, a continuous capacity building. That report indicated there's a gap in diagnostic accuracy. How do you bridge that gap? It has to be that formal continuous running, and the health workers have to be given that opportunity to go and enhance their skills. The basis, the foundation of health is the worker. If they are not motivated, they cannot do it. Then the issue of governance and leadership is a big animal. There is have been a lot of debate since the devolution. People are having divergent views. Should it be centralized human resources? Should it be devolved? They give examples of various countries, and even some countries who have done well, others have not done well. So the issue is, as stakeholders, can we come and give a concrete direction? This is an opportunity for us from this result to have a dialogue with policymakers. Tell them this is the result. How do we manage the health system, especially the part of human resource? That's very key for us, and I think it's one of the areas we want to run with the KMA and all the stakeholders.
Right. I mean, it is perhaps a tricky question to respond to, but perhaps you have a different view because you're right in the thick of it. Do you think that there is political will?
Political will.
Although might I add, there's one thing in having the will to do something, but then there is the other aspect is actually implementing and doing it.
For a long time we have not had health as an agenda. In 2017, the president declared UHC his agenda. Already that is political will at the highest level. The Kenya Medical Association president and vice president Kitulu went to Israel, and President Uhuru Kenyatta was acknowledged in a conference on universal health care as political goodwill. You get, therefore we must never look that down as that's a big step. The second step is now listening to the healthcare providers. What do they want vis-a-vis governance? For instance, the biggest fight we are having with the devolved health system is the governor not seeing the need for the health worker to be autonomous, to run on their own. And I always say this, health was more devolved before the evolution of health.
How or in what
than it is now. Health is currently centralized. Why? And we had discussed with Peter here that NCPD had done a survey using Kenya Demographic Health Survey in the year 2004. Their recommendations was that health needs a strategy, what we called now reversing the gains. And they said we need autonomous health units, centralized performance policy, but run by the health workers. And it was fantastic. And if you look at between 2007 and 2013, that's what happened. So for instance, they used a very good example of a thermometer. A thermometer in a dispensary, if it breaks down now, you have to call the governor to give you money to buy the thermometer.
Right.
Previously, before 2013, there is a hospital or a health facility management team. Yeah, someone reports, and there is a fund that has been budgeted for in 3 monthly budget cycles. There's money because they know a thermometer can break. So service delivery is not interrupted because money is centralized. What happened in 2013 when the governors met the then Director of Medical Services at Laikipia Regency in June is that they say no, they want the money of health because we had done very good work of improving money collection at the health facilities. This is not theoretical. I was a medical superintendent at Isiolo District Hospital. Our facility improvement fee, the one that we used to buy the thermometer, was 6 million per year in 2007. By the time I left and handed over, it was 24 million.
Wow.
And therefore, a governor coming in, he's seeing that money as a source of money. So what happened? They closed the hospital accounts, which the money used to come and they use it to hospital and centralized it, made it county. So money enters the county, and then the hospital workers, they now, ownership was removed from them. Because even previously, when you want to tell them, by the way, we do not have money to do ABCD. Let's say people want to go for a conference. You tell them, hey, by the way, your department has not made enough money to allow you. And they work hard the next year. So now health is less devolved than previously. Because previously, management of health facilities was at facility levels. Currently, management of health facilities at county level. So health is not devolved, literally, and it's worked very well. But now, if maybe someone can commission NCPD to do a study on the effect of facility improvement fund before devolution and during devolution, and then we can answer that question too, so that we don't look like it's a political argument. And therefore, we are not saying, we actually don't want the health facilities. We just want the management of human resources for health. And Professor Nyong'o, during the funeral of Laboso, summarized what health is. He said health is research, empowerment of the health worker. And he actually said, yes, you people will build cancer centers, but who will be doing the research and who will be doing the work? You see? And therefore, we must really look into this management of and professional associations. Now coming to the report, and maybe where I had some challenges with him is that we don't know whether Ministry of Health was involved. Ministry of Health is the health branch of the government. They are in planning. So what we are saying is that maybe they need to incorporate the professional associations like Kenya Medical Association in this analysis, and also that we can also educate the country from a perspective of not look like government, because you know again the image of government sometimes can cloud good things. Right,
and I wanted to come to that because you have been mentioning, Peter, the importance of moving forward partnership between various organizations. So what is your comment on that?
Before I comment on that, there's something you mentioned and we need to notice the rules at it.
Yeah, go ahead.
Management of health services at the facility level. In this report, we did analyze and find out, are the health facility management team in place? And you will see in some of them they are not in place. So if they are not in place, who is making a decision at the facility level? And that's an area now we need. How do we strengthen those at the facility level for day-to-day policy direction, and even the resources at the facility? That's now where you find there's a challenge. The issue of partnership, health is something which is not cheap, but it's a priority for the country. It's a catalyst for all sectors of the country. There are a number of partners out there who pick one aspect to support, another one picks another aspect to support. But if we have got an overall coordination, we say that our priorities through the strategic plans is say in a particular area, we cluster the counties and say now who is there, we do the mapping, and then we give priority. As they are coming, we are telling them, you are going to Isiolo, where Dr. was.
Yeah.
This is the priority in Isiolo.
Yeah.
Right.
Focus on this. In Kirinyaga, you have seen what is happening. This is a priority. Partners who want to support Kirinyaga, this area. What's happening now in the country is that you find some areas, equity, the issue of equity comes in. Partners are coming and running to a particular area, then now attribution of their contribution is minimal. You cannot know who is contributing what.
Yeah.
But if we have what, such a coordinated, structured way, saying so and so is going to this county, these are the targets, and this is what we will give, and this is how we are going to measure the input. That will be very key. It requires a lot of consultation and support at all times.
Right.
And we are willing to read that process because we are coordinating agents to bring the stakeholders on board. We agree how we move. Where there are gaps now, we have those are mandated to solicit for resources. We can't solicit.
So with such a report, what do you hope the outcome of this is going to be, in the sense that who now needs to act on the report? It has been, immersed by the media, for example. There are various articles about what's happening, but what action now needs to happen?
From the past, what we used to do when such a report comes out, now we go back, sit and do wide dissemination first for people to understand. We'll move to gray areas where people are not clear.
Right.
Wide dissemination. Then now we could have targeted interventions. We will meet policymakers, sit and dish out what are the policy issues in this report. And then we will be action to implement it. What are the program issues in this report? Who will be involved? Then the action. There may be legal issues which we may need to have a conversation with the parliamentarians to say we need changes here. But it will be a consultative process, participatory. So I'm seeing for the next 6 or so years, focusing on this report so that intervention is done.
Right.
And we are happy that this report is coming out when the current government came into power for this 2018. Now it can be a benchmark for each county,
Right.
because we have what county-specific indicators, so they can be able to trace what they did, what measures they have put in place.
So if I'm not wrong, the previous report was in 2012, is that
Yeah,
correct?
it
So
is.
when will the next report be? In 6 years' time?
Usually it's supposed to be 4 or 5 years.
Right, okay.
It's between the successors.
Okay, so we hope to, at least in that period, see some sort of implementation and some sort of action taking place.
One of the things I may add that when we were designing this study, we also wanted to have the community component,
Right.
to get the aspect from the community. How do they perceive the services? Because of the resources and at the timeline, we were not able to do.
Okay.
And that's one area we would need to commission another study,
Okay.
see what is the perspective from the community, the clients. So that's another area we need, so that it is merged.
Okay.